Um, she, as many of you may know, is an expert in issues in global maternal health. The epidemiology of really women's issues, pregnancy-related issues, child development issues. She's studied this throughout the world. Very international. She's been to lots of different countries, and even WISVILLE. They've all. So this afternoon, she's going to tell us a bit about what she's learned over the course of her research career, where she's going, reproductive health and women's lives. And shut up now. Dr. Wallis.
Thank you so much. And thank you, both you, Dr. McKinney, and Claude, soon to be Dr. Davis.
Yeah.
Can we do the lights? Yeah. Let's go ahead and get started. So I'm going to talk for maybe 40, 45 minutes, and I'd like to wait to do questions at the end so that we don't get slowed down. So I'm going to talk today about reproductive health, specifically women's lives in Kentucky. I want to focus on maternal deaths. We need to talk as a country, as a state, as a group of public health professionals and epidemiologists about preventing, slowing, and ending maternal deaths in Kentucky, because it's actually doing. So we know Kentucky as the bluegrass state, thoroughbreds, gorgeous mountains, more thoroughbreds, just because. Beautiful cities with a lot to offer culturally and intellectually. Racing. Kentucky was once a very prosperous coal mining state and is less prosperous now. Kentucky has been a major producer of tobacco and tobacco products. And consequently, or at least it's associated with the fact that we have one of the highest smoking rates in the country, including among pregnant women. We've had an opioid epidemic that's hitting rural Kentucky, particularly hard. We still have serious issues with socioeconomic and racial bias. And again, heroin epidemic doesn't start or stop with adults, but also children, and it seems to. So what does all of this have to do with reproductive health? I would say everything, because context matters. Those of you who know me know that I like to start my classes and anything new we're thinking about with some historical and contextual background. And that's because context interacts with populations often and in different ways to produce either good or not good health outcomes. So in reproductive health, we cover a lot of different areas, from perinatal health to adolescent childbirth to nutrition, tobacco use, fertility and assisted reproductive technology, cesarean section rates. But what I'm going to focus on today is maternal morbidity and mortality, because it's an important problem, because it's preventable, and because a lot of the things that we do to prevent and treat maternal morbidities and issues during pregnancy can help with all of these other things. They all are interwoven. So how are we doing as a state when it comes to maternal mortality? Not so great. In fact, our grade is F, according to the Population Institute. We're in good company. There's only about 10 states with an A, and overall they rated the U.S. with a D minus. These are the grades. The red states are the Fs. The yellows have a C. The blues have an A. So that's what we look like across the country, which means we have an awful lot of work to do. So Kentucky failed on this particular rubric, which doesn't cover everything, because even though Kentucky mandates sex ed in schools, it does not require that HIV education include condom use or that sex ed include contraception. So that's not good. Kentucky had a model expanded Medicaid program that has recently added waivers such as requirements and lockout penalties that limit who can use expanded services. That. And several laws have made it increasingly difficult to get a state abortion. And 74% of women live in a county without abortion care. So maternal mortality. I'm going to have to start with some boring details, like definitions. But actually, before I get to that, I want to give you the numbers. So the U.S. maternal mortality ratio is what we call it, is 26.4 for 100,000 live births. That is a terrible rate. It is approximately, well, double and in some cases triple the rates we see in Europe. And it has apparently nearly doubled in the past few years, and we don't know why. That's the big question. So the darker states here have higher rates, 23 for 100,000 in Texas, and in the Southwest, the Southeast. Kentucky at 13.5 is kind of in the middle, which is a good thing, but not at the top where it's under 10%, California being a notable exception. This is the mortality ratio for non-Hispanic Black women. And this is where it gets really, really so. So overall, the ratio of maternal mortalities for Black women in the U.S. is approximately double that of non-Black women. This, again, the darkest states is 34.3 per 100,000 in Kentucky, 56.5 in Texas, 83 in Arizona. And these states didn't have enough data to show. And if that's not sobering, I don't know what is. This is us since 1990 in comparison to Germany, France, Japan, England, and Canada, who should be our peers in health, economics, education, industrialism, right? Industrialization. But since 1990, our rate has gone from being just below Germany's and pretty much the same as France, to 26.4, where the rest have uniformly, and I can add like 20 more countries onto this, and they would all have a downward slope except for us. So something's going on. Let's start with definitions. So maternal mortality is defined as the death of a woman while she's pregnant or within 42 days of termination of the pregnancy, irrespective of the site or duration, from any cause related to the pregnancy or aggravated by the pregnancy and its management, but not from incidental or accidental causes. Now, it's going to get more complicated here. The maternal mortality ratio is how we count or define it in a population. It's not a true ratio, but we call it that, so you just have to go. So that's maternal death per 100,000 live births. So then it gets even better. We separate out direct and indirect obstetric death. So a direct obstetric death is when a woman dies of an obstetric complication or from a chain of events resulting from pregnancy. So for example, a woman dies of bleeding out or preeclampsia. Then we have indirect death. So this is where a woman has a pre-existing condition that is aggravated by the pregnancy and she dies. For example, a woman has cardiovascular disease before she's pregnant, but her pregnancy exacerbates the condition and she dies. That's indirect. So direct plus indirect equal all maternal mortalities. But then we really had to confuse this, right? So the CDC, the WHO, have introduced this definition, which is a pregnancy-related death. And that includes the death of a woman while pregnant or within 1 year of pregnancy from a complication or aggravation of an unrelated condition by the physiologic effects of pregnancy. What does this do to our ratios? Immediately, if we count pregnancy-related mortality instead of defined maternal mortality, they're going to go way, way up, right? Partly because we've included a whole year, so we're capturing more women, and because of increased possibility of getting the diagnosis or cause of death. So we have two main sources of maternal mortality data. One is the National Vital Statistics System. So they report on maternal and late maternal deaths. Late maternal are the ones, this includes after, it doesn't include after, sorry. So these are within the 42-day window and deaths coded using specific ICD-10 categories. It uses only information from the death certificate, which may or may not include the pregnancy checkbox, which will be something to talk about in a second. The second big system, also conducted by the CDC, is the Pregnancy Mortality Surveillance System, which reports on the 1-year pregnancy-related deaths. It uses all available information on the death certificate, and it matches with the birth certificate of the result of the pregnancy to clarify and make sure classification is correct. So cause of death is then classified. So it results in slightly different measurements, as you might expect. The red line is the one where they match birth and death certificates and show and are able to look a little more closely at the cause of death and make sure it's correct. And that still, I would say we have an upward moving slope, but it's not as bad, and lands us at 7.3 per 100,000 in 2014. The maternal mortality ratio on its own, which is using the 42-day definition and not matching or individually checking birth certificates, gets us much higher, to 21.5, and then in the last 2 years up to 26. The number of deaths in the U.S. is about 700. In Kentucky, we've had 74 maternal deaths between 2011 and 2016. Now, you can look at that and say, hey, what's the big deal? These are not big numbers. The problem is that these are, maternal mortality is a sentinel measure, a lot like infant mortality. What maternal mortality and infant mortality show us is the overall health of our population and kind of a check on how well our healthcare system is doing. Also, like an infant death, it's very, very preventable. So let's talk about death certificate ascertainment for a second. So in 2003, there was an international recommendation made to include a pregnancy checkbox on all birth certificates all over the world. And remembering that most births in the world are not in a country that even has birth certificates. So we kind of think hard and have ways of developing a probably inaccurate maternal mortality ratio for a whole lot of the world. So this would apply to the countries that actually have death certificates. As of now, 35 U.S. states have added that checkbox, even though they've had 16 years to do it. Kentucky added it in 2010. The checkbox looks like this. So if they're female, were they not pregnant in the last 42 days or in the last 12 months? In other words, were they pregnant in the last 42 days or last 12 months? And were they pregnant or were they pregnant at the time of death? So that's a really wide open checkbox, isn't it? Adding the checkbox almost instantly doubles the rate of maternal deaths. It could be because we're overcounting. It could be because we're more realistically counting. Or there could be some misclassification or some of all of the above, including lots of false positives. So this is just another figure to compare again the published MMR with the pregnancy-related rate. So the black line is the PRMR, which you can see is rising a bit, but pretty steady and doesn't look nearly as bad as the MMR, which is clearly going up. But then if we shrink the PRMR to just 42 days, it's a lot more steady and looks like this. The answer is, in the US, we actually don't know what our maternal mortality ratio is. And in Kentucky, we definitely don't know for sure. That's a big problem. Now, what we don't know is whether the countries that we compare ourselves against, European countries, Australia, Japan, New Zealand, Canada, are really doing it any better or not. They might not be using the pregnancy checkbox. In fact, a lot of them aren't, and they may actually be undercounted. So this is the list of countries, and I know you can't see this, but this is a long list of European countries, and whether or not they have a pregnancy checkbox. This was as of 2007. It was literally the only thing I could find. And so that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 11 countries out of all of those. So that means if they don't have the pregnancy checkbox, we're comparing apples with oranges, right? So that might make us breathe a little easier for the moment, sigh, breath of relief, but I don't think it's going to fix it. I want to quickly show you some sociodemographics. And this is national, but it's mirrored in Kentucky. So overall, the green is 2008 to 2009. The blue is 2013 to 2014. This is the important one. The non-Hispanic Black maternal mortality ratio is staggering. This is the white maternal mortality ratio, which is also high, but not nearly as problematic. And so what we really worry about is why. Why is that there? This shows by age. Most of the maternal mortality that we've seen in the last dozen or so years has been among women aged 40 or over. Now, something else we also know demographically for probably 30 years is there's been an increasing number of women, or percentage of women in the U.S. over 40 who are giving birth. And that's a very high-risk period. So that's also a piece of the puzzle. We have, and this has been all over the news, and I hope you've been catching it, there was an excellent NPR series on maternal mortality in the U.S. We have the worst rate of maternal mortality in the developed world. Let that sink in. This was an article from the Courier Journal about maternal mortality, specifically in Kentucky. The wife and mother of this family died in labor. The baby died. And although it was counted as a maternal death, the Maternal Mortality Review Committee, which I'll talk about in a minute, and is generally a good thing, did not review this death. So the Maternal Mortality Review Committee, like a Fetal and Infant Mortality Review Committee, a FEMR, is supposed to review every single death. That's our recommendation for developing countries. When I'm traveling around the world and we talk about maternal mortality, we're always on about this. America knows this too, that every single death needs to be reviewed. Everybody involved with the family, the clinical care gets interviewed because we have to get to the bottom of why. If we know why, we can take steps in the future to make sure that that chain of events doesn't happen. If we have 74 deaths over, what did I say, nearly 10 years, and we didn't review this one, it's a little bit problematic to me. So, why are women dying in the U.S.? Why are women dying in Kentucky? And who is dying? Why? How many? And are these excess deaths? Is it an artifact of reporting bias on death certificates, or are they real? We have got to do better. There is no acceptable level of maternal mortality. We know that somewhere between 65 and 70% of maternal deaths, for sure, can be prevented. It's probably more, especially when you think about the underlying upstream causes of deaths, including infant and maternal deaths. And that has to do with socioeconomic conditions, access to health care, discrimination, stress in the environment, pollutants, etc. Kentucky, unbridled spirit. I think, there's a good slogan there. Love the horse. But we have a lot of room to do better, and fortunately, there are some recommendations that can really be fully implemented because they've been done in other states. So what can we do? First of all, there are now 33 states with a maternal mortality review committee. It's like it should be, comprised of health experts. And what they ask is, for each death, was the death pregnancy related? What was the cause? Was the death preventable? What were the critical contributing factors? What are the recommendations and actions that address those contributing factors? And what is the anticipated impact of those actions if implemented? And it should really be even more than this. But that's the basics of what an MMRC should do. We have, in contrast, we have fetal and infant mortality review committees, not only in every state, but in many locales. So cities have them as well. And this brings me to a point. In the last, well, since the 1980s, in the US, we have become very, very, very aware that we have a terrible infant mortality problem. And that, again, against the rest of the industrialized world, we stack up pretty poorly. So we made some real efforts. Starting in 1989, George Bush passed legislation to fund the Healthy Start program. Millions of dollars every year. It started with seven demonstration or 9 demonstration grants in 1990 in the highest risk cities and rural locations in the US, including an Indian reservation, to hone in on infant mortality. It is now hundreds of grants across the US. Healthy Start is a very established program that does everything from home visiting to prenatal care to postnatal care, preconceptional care, and then different variations that are meant to reflect what the communities look like. And they are also working on narrowing disparities. So we've actually dropped our infant mortality rate in the US substantially since the 1980s, and we're down to about 5.9 per 1,000. So we can still get better. Finland and Japan have just around 2 or 1.5 per 1,000. So there's a good way to go. And we can't say it's all because of Healthy Start. But we can say that there's something that we do not only in the US, but across the world, to really focus on babies. We don't focus enough on women. So there are many more programs in the US and across the world that focus on neonates, babies, and young children in order to curb or to improve child survival. Not nearly as many that support women or attempt to prevent maternal mortality. That issue, the press has been bringing it up, and actually legislation was passed just this past December and signed by this president to specifically fund maternal mortality research and programs to prevent maternal mortality in the U.S., and that includes establishing a maternal mortality review committee in every state. So, I want to get down to recommendations and what I think can be done about it. Fortunately, we have a great example. In 2006, California noticed that they were seeing an increase in maternal deaths. And they kind of panicked, put all hands on deck, and made some serious changes to lower it. So as of 2013, this is where California sits with maternal mortality ratio. And here's the US overall. So California is looking more like France and Germany. So let's see what they did. There's been some attention in the press. The New York Times, the last piece that I showed you was from NPR. You can click on the link. And this is a very nice study done in Health Affairs, published in Health Affairs on exactly what the state of health is. So here's what they did. Step 1, link public health surveillance to action steps. Okay, we talk about that all the time, especially in NPH programs. That's like one of our indicators, right? One of our, what do you call those that we've been working on? No.
Indicators.
Indicators, okay. for how we're doing, for how we're training our students. So we really care about surveillance and action steps to policy or program. So they immediately initiated a mortality review project, which was a multidisciplinary committee, including maternity, perinatal, public health experts, to conduct really in-depth case reviews of every single step, just the way we say it should be done. They ascertain causes, demographics, and determine opportunities for future improvement. They link their epidemiologic investigations directly to action with quick communication of findings. They actually update their maternal mortality stats every month. And they've developed large-scale quality improvement efforts, including they've got obstetric hemorrhagic task force toolkits they've developed for hospitals. They've also developed one for preeclampsia and for some of the main causes. They convene peer learning groups, work with hospital staff statewide, and have intense improvement collaboratives that are people really on the ground trying to figure out what do we do when that one case is in. So a big piece of this is recognizing that, or maybe getting away from this idea that pregnancy is normal, natural, and always goes well, or mostly always goes well. The problem is when it doesn't, it goes south fast. So some physicians in their training, many physicians learn, if you're looking at a herd of horses, there's no reason for looking for the zebra, right? Because you've got a whole herd of horses. But here, when we have high-risk maternal admits or a maternal admission that is showing, say, hypertension with protein in the urine, that becomes the zebra. And recognizing that zebra early is important, and having a toolkit, guidelines, and practiced procedures to respond to it makes a difference. So they mobilized this broad set of public and private partners across the state. Remember, California is huge, but that could be done here too. And made it a hub for convening stakeholders, generating new ideas and leveraging resources. And the California branch of ACOG, the Nurse Midwife Association, and the American Family Physicians Association publish updates in their newsletters regularly. And they create really firm linkages between and among hospitals to share metrics, topics that cross professional boundaries, for example, clinical medicine and social determinants. Step 3, and this is a big one. So I always believe that it's about data, data, and more data. The better data we have, the more we can do, right? So they established a real-time maternal data center to be a low-burden, low-cost, rapid turnaround data system capable of efficient data entry, compatible data systems, imagine that, and rapid reporting and feedback. It gives them an ability to benchmark, to compare hospitals with similar sizes and expertise for all births, and provides a data capture for every single birth. So it's a matching, it's a birth record, and if there's a death, a matching infant and or a maternal death. Right. So Florida, Massachusetts, and Ohio also have rapid cycle maternity databases. So those are smaller states. This can be done. Every month, the center links birth with maternal and infant discharge data. That is admittedly a really big effort, but it's a very important effort. Most states, including Kentucky and other states I've worked in, it takes usually into the next year to have a thorough count of the number of births, deaths, infant and maternal, from any one state. And that's too long. So because birth data are collated and shared within 45 days for each month, it focuses attention on the quality of birth data and on the individual cases, making it a win-win. Step 4, they implemented focused public health, and clinical intervention projects. The interventions are based on solid data foundations determined from steps 1 through 3. They developed quality improvement toolkits and guidelines, and trained and did technical assistance through learning collaboratives. So here's, I know you probably can't see this, but the takeaway message from this is baseline severe maternal morbidity. So that's what we call near misses, which we also study, because a near miss can tell us what we did right or where we almost went very wrong. So the rate of near misses for hemorrhage dropped significantly in 2 different types of hospitals. Total of about 250 hospitals in the sample dropped by around 20% average. So that's a real dip in a serious issue. So here's what's happened with their disparity ratio. So down here are Hispanics, whites, and Asians. Pretty well clustered. This is the Black mortality rate, and look, they're closing in. So something is going on that's right, that also addresses racial and ethnic disparities. So some concrete recommendations for Kentucky would be following evidence-based practice from other states. It is possible to replicate programs. We do it all the time. Data, and again, did I say data? We need to frequency and definitions between that 42-day, 1-year thing, between indirect and direct. Definitions people know and understand. We all understand infant mortality and how to calculate it. Maternal mortality, much more difficult and inconsistent. We need to reject the idea that childbirth is normal, because you know what? Sometimes it isn't. Focus like a laser on maternal deaths, the way we did on infant mortality. Develop maternal mortality review committees for every state. And thankfully, there will be some money to do that. It's $12 million a year from the federal government, which doesn't go real far, but it's an important signifier and I think an important message. And we can obviously encourage our legislators to do better. And, we can work to make sure that this improves our maternal mortality review committee and that we can start to follow some of the procedures that states like California. So I want to end with a hometown hero, upbeat quote. This is a depressing subject. The numbers are sad and tragic, but there are definitely proven things we can do to make it better, especially in a state like Kentucky. The only limitations one has are the ones they place on themselves. Muhammad Ali. So, I can take questions. Yeah.
I was wondering, with the reduction in sexual Arkansas, because they have a lot of improvement in quality of access to that data, do you know what they actually did to address those changes? Was it mainly with their medical ones, or was it addressing some
It was actually mixed. So it was a clinical lens, but also very importantly, they were considering upstream factors as well. So that means prevention, it means public health, and it means community health. So that could be improving hospitals, improving provider knowledge, which is really important, and other things that we would consider as public health. So yeah.
Did they able to address if they can get away from work, legal visits, or when they go back to work?
So I think that falls under the category of things they're working on, because we know that from a policy perspective, that's the kind of thing that has to change. Not every woman can take a break or going to a prenatal care visit without losing money from her work. The good flip side, at least regarding prenatal care, is over 95% of women in the U.S. get prenatal care. So we've gotten actually pretty good at that, and it's even higher in California. So that's happening. What we have to worry about more is the quality of prenatal care. So it's there, but in some places it's better than others.
Do you notice that maternal mortality rose as women get as the same?
So, yeah. So his question is, maternal mortality has risen as abortion access has decreased, right? So that has been brought up. I would certainly predict that there could hypothetically be a relationship. And I really think about Texas, which has clamped way down on Planned Parenthood clinics, and they have the highest MMR in the country. So what does not having safe abortion means? It means that women get abortions anyway, and that means they're getting unsafe abortions, which leads to often sepsis, hemorrhage.
So just going back to the California thing, California has probably the best economy in the states. How do you think that how do you think economy and health?
They're related. So they're almost exactly associated. The better the economy, the lower the maternal mortality, lower the infant mortality, the lower the child death, lower almost everything. California does have a good economy, and when you look at these steps, it has to be said that while they are viable, replicable, and sort of easy to sum up, they're not cheap. So that would be a direct relationship. But yes, there's a relationship between economy and health outcomes. So that would be something when we're looking at Kentucky that you really know that we have to fix. When I showed those slides in the beginning, they show regional differences in our context here, whether it's because you're in a rural area and don't have access to high quality care, or it's a long way to a tertiary level hospital to deliver in, or that those rural areas are often poorer, that they might be more subject to the opioid crisis. Those are all issues, and they have to do with wealth and with wealth equality. So that's a great point.
I'm interested in the maternal mortality review meetings, and why do you think they have scaled up on that?
I think it goes along with this thing where we've really emphasized fetal and infant deaths. And that's where we've put a lot of our money, and maternal mortality has somehow gone under the radar while we're like focusing like an arrow on pregnancy and even 0 to 3 programs that we've done a decent job. I really kind of think that's a lot of it.
There's a federal mandate that requires each state to have.
No, but there will be as of December 2018. But that's like kind of late in the historical game here, isn't it? Yes.
So you mentioned sexual education in the presentation. Did California do anything like that? Or
So they have different rules about sex ed to begin with than we do. And I'm not going to be able to tell you exactly what they are, but they are less restrictive than our sex ed.
So data on association, more comprehensive sexual education.
So there probably is, but I would be careful with associations like that. I would bet that an association exists, but confounders abound.
I was interested in the slide that showed it showed Hispanic white. And,
Yeah.
Mothers, if Hispanic is lower than white, which is not something I'm used to seeing, and how that slides.
So there's this thing called the Hispanic paradox. So in infant and maternal outcomes, Hispanics do as well as or better than white populations, especially in the first generation they're in the U.S. So we see that with infant mortality rates and maternal mortality rates, and we're not totally sure why. So it could be, we would expect, so even if you control for socioeconomics and look at white, black, Hispanic, still the Hispanics have better infant and maternal mortality outcomes. So, you know, that's a really good question to dig into, is what is so resilient about the Latino populations that we can use? And it may be that they're subject to, say, less racial bias in the course of their lives than a black woman. It could be that. Yeah, it's paradox. They have class.
I have a question.
Yes.
As far as my study interest, infertility in general,
Yeah.
do you think infertility plays with child health as far as people waiting longer to have
Yeah.
kids, and then what ART? Think it plays a role?
I think the age plays a role, and that's pretty clear from the data. And the other way that I can think of that it plays a role is because ART is much more available than ever before, and because women are waiting longer to have children, that there could be sort of I'm not going to say a perfect storm because that's cliche, but there could be something coming together there. So you're waiting longer, but also another way of thinking about that is women who can afford to get assisted technology for reproduction are seeing the best doctors usually. One really great question would be, are those the women who are dying or not? My guess is not, because they're very closely watched.
But just wondering, so with the infant mortality and the maternal mortality, say, like that, the infant mortality is pretty low. What was that, I guess, historical concept that kind of pushed this big urge to look into infant mortality and kind of start to neglect maternal mortality?
So it was this sudden recognition that compared to other industrialized nations, and I think now we're at a moment when we're seeing the same thing about maternal mortality. It's making the headlines, and I think it's an eye-opening, important moment that we can use for real action.
Just to follow up on that, what do you think that like normal citizens can do to kind of push this forward?
So I would start with the fact that everybody in here is getting trained in public health. So more public health knowledge and people better trained. Secondly, there's always the right to your legislators, which we always say that, but I don't think that's done at all. I would definitely do that. In fact, I do it. And then I think we need to really make sure, and I'm not quite certain how to do that except in forums like this, which is making our health departments advocates for maternal health. Often our health departments in Kentucky are less well-staffed than we'd like them to be. We certainly don't have enough staff to start a data project like California. With increased political pressure, we can get better policies and money. And I think that's what has to happen.
So one of the recommendations that Scott looked at pregnancy as normal and generally healthy. What do you make of like the medicalization of birth and pregnancy and like a really high C-section?
So the high rate of C-sections is a real problem. We are Kentucky is 7th in the nation for the highest rate of elective C-sections. C-sections, especially repeat C-sections, are a risk to the mother and to the infant. So that is something that absolutely has to be taken care of. You said something else right before that.
Medicalization.
Oh, the medicalization. I'm going to just go out on a limb here. I'm remembering that I'm an epidemiologist. I think I'm a smart one, but I'm not an obstetrician. I don't really have a problem with it. I think it is a safer way to deliver babies. And that's what we're trying to do throughout the developed world, too, is get more women into hospitals on time with trained personnel.
I wasn't talking about birth outside of hospitals, I think the trend.
The overall, like C-sections and, well,
increased intervention.
Yeah. So what I think about it is that we have to be smart with our time, money, and resources. So why are we spending a lot on excess C-sections and not as much on preventing hemorrhage or identifying preeclampsia? Be my answer.
It's like a really high risk of infections.
Yeah.
So it's beneficial to have nurses and trained doctors.
Well, that's a good question. So her question is we know that there are significant infections. The infection risk in a hospital is high. Would it be better to have home births with trained professionals? I think home births are, from what I know from the literature, is that when it's a very low risk mother and a very well-trained professional who is in a very hygienic situation, in other words, pre-prepared, then the data don't really show that to be problematic. The issue is if something goes wrong. I don't know the really precise answer about infection, but it's a really good question. Anything else?
Can I just jump up and say something?
Sure.
So, my name is Josie Raymond, I work at UVille, but I'm also a state representative, and so, Wallis,
right.
emailed me in Frankfurt if we actually started that's what the being. And so I'm hopeful that I can turn some of her work into legislation next year. The legislature did pass this year, a bill through the House and Senate. It's now, I think, with the governor for his signature, and I believe that he'll sign it for licensed certified special midwives.
Right, and that's because we haven't had that.
It's not going to, like, you might see the rate of births increase the protection in.
Yes, absolutely. Thank you for being here. Okay.
Well, thank you all for being
Thank
here
you.
today.